Right. Hi, everybody. Thank you all for joining us this evening. We'll give everyone about a minute or so to log on. And while we're doing that, we'll just get started with a couple of housekeeping items. My name is Brooke McGiver, and I'm a speech language pathologist here at Timms Medical. And I am honored to have Dr. Eric Blicker with us this evening to present Fees After Extubation. Timing is Everything. A couple of quick notes. If you are interested in obtaining ASHA CEUs for this course, we ask that you stay for the entire hour-and-a-half duration of this session, after which we will ask you to complete a quick survey. The survey will be posted in the chat, and it will also be emailed out via Zoom immediately following the conclusion of this session. That survey will be open for 7 days, at which point we will submit for ASHA CEUs. If you are interested in obtaining a certificate of completion, just send us an email at tims-univ@tims.com and we will get that over to you. And if you missed any of this information, like I said, this will be in the chat. As we proceed through the session, feel free to pop your questions in the chat or the Q&A box, and Dr. Blicker will answer questions at the end of the session. With that, I'm going to hand it over to Dr. Blicker.
Okay, well, thank you, Brooke. It's always an honor to collaborate with you. Thank you, and thank you to Timms for having me here this evening. This is a topic that is very important to me on a professional and personal level. Having had family members who have been intubated, having had family members with neurologic conditions who have been intubated, it just brings about a whole new level of care for these patients when you're watching things happen personally and watching things happen professionally as well. So you may hear me talking loud at certain points this evening. I don't want anyone to think I'm yelling. For those of you who know me, I do talk a little bit louder when I present. I'm very passionate about the topic. I'm also from New York City, so sometimes I talk a little faster. So if there's anything that you need me to reiterate, slow down, just feel free to let me know. I'm happy to do so. So we'll start off with a little bit of humor, but not so funny. The endotracheal tube is not wrapped around someone's legs. Have we ever seen an endotracheal tube in person? Here's one. Okay, so it is manually placed in the mouth by an emergency services worker, respiratory therapist, nurse, or doctor, manually placed in the mouth between the true vocal folds, and then the outside is outside, this piece is outside the mouth, connecting someone to a ventilator. So to put this in is intubation. To remove this is extubation. Very big difference to tracheostomy tube. So I just want to make sure we're all on the same page. Tracheostomy tube, different story, different course. Surgically placed in the neck, below the level of the true vocal folds. Your goal of a tracheostomy tube, different. Speaking, voicing, eating, drinking, those are goals. With a tracheostomy tube, when you are intubated, manually placed tube, much larger, eating, drinking, speaking, phonating are not possible. So I did want to kind of start off. I know that might sound basic, but we're all at different levels here. An endotracheal tube, much, much larger than a tracheostomy tube. So that's important right off the bat, okay? Interestingly, both have a pilot line and a pilot balloon, and both have a cuff. So you are inflating and deflating in a very similar manner. My disclosure, I'm being paid an honorarium from Timms for this presentation. My non-financial disclosure, I don't have any non-financial disclosures at this time. You should know about me. I work as a clinician in New York and Florida right now, seeing patients. I've been licensed in 4 states. I've been seeing patients for 27 years. I don't always think that doing something longer makes something better. Throughout those 27 years, I've evolved daily as I learn more and see more. It brings me to the forefront of how I can best help my patients. So in that 27 years, a large portion of that time was involving clinical care 7 days a week. I also train fees around the country. I've been training others in fees since November 2001. I was trained in fees from October 2000 to June 2001 at Columbia Presbyterian with Dr. Aviv, a medical doctor and a speech team working together. I've worked with fees in every adult setting possible, from LTAC to acute care to home care, and many different sites in between. Happy to take any questions you may have on any of those particular treatment areas. I do have to ask this request with my slides. I would ask you to not post these slides on social media. Just want to make sure that they kind of don't wander off. I also would ask you to not use these slides for your own financial gain. If one of you wants to reach out to me and likes a slide for a presentation you're doing for grand rounds, for medical student interns, for a nursing home, for marketing, for a state presentation, I'm very happy to help you. Just email me on a one-by-one basis, and I'm happy to grant you that type of permission. So that's something important I wanted to share with you. So, intubation, many different times that this is being done. It can be done in the field. Someone being brought in by emergency medical services. These tubes can be put in by an anesthesiologist prior to surgery. These tubes can be placed in the emergency room. Some might think the better the optics, the better the visual field that the practitioner has, maybe the better intubation success. That's not always the case. Sometimes we've just got to think about the technique. Technique is a big important factor of why this topic is so important to me. So let's think about risk. Let's think about cost. It's unique for our field that this type of dysphagia has its own acronym, PED, post-extubation dysphagia. So if we consider how many people have acute respiratory failure, how many patients survive their time on a ventilator, how many of these patients then get extubated, we're often called in to assess risk, the risk for aspiration. Now we know, and I'm not going to get into a whole separate topic, that not everyone aspirating develops pneumonia. We all understand that. There's a wide variety of conditions present to develop pneumonia, including bacteria, including oral hygiene, including being dependent on others for feeding, tooth decay, a whole host of factors. So we often say, well, not everyone aspirating develops pneumonia, but there are other things to consider here. A large part of my work in Ohio for the 4 years that I lived there involved working with patients with COPD. Patients with COPD, they don't always have the same inflammatory response. Many of those patients who aspirate actually develop COPD exacerbation. So while pneumonia risk is present, there are other byproducts of aspiration, including COPD exacerbation, including dehydration, including malnutrition. Okay, so why would we want to push for such use of instrumentation prior to following a breathing tube being present? Because all of the factors associated with that breathing tube being present are being run by objective data. When someone is intubated, they have an x-ray every day to make sure the endotracheal tube is in the right location. It actually has numbers on the side of it for that very purpose. You may see the radiologist notes telling it to be advanced, pulled back. These patients daily are having blood draws to look for elevated white blood cell for infection. These patients are having arterial blood gas to look for O2 saturation and pH level on a very regular basis. So if all of this objective data is being utilized to manage these patients, why should we be limited to a clinical exam only? And it's part of my mission out there right now to get as many people trained in FEES as possible, because I think it's going to elevate our field, and I think it's going to ultimately help more patients. So the risk, when we get called in by nursing post-extubation, and this can be acute care, LTAC, skilled nursing, acute rehab, we have to think about risk factors. Risk factors for severity of patient presentation for dysphagia, right? So if we look at visible frequency of spontaneous saliva swallows, we can see that at the bedside. We can see a patient at the bedside whose mouth is remaining open, who's not producing many spontaneous saliva swallows. Some of those same patients post-extubation in acute, long-term acute care often have something else going on, retention of secretions. The very first secretions rating scale from Dr. Joe Murray back in 1996 said for hospital patients who are not producing saliva swallows, who might be retaining secretions, there's greater risk for potential aspiration and potential sensory loss being present. So there's your product of sensory loss here. Now, when we talk about spillage, residue, penetration, aspiration, We're not saying that those events are catastrophic. And in fact, for many patients, spillage into the throat prematurely before the swallow doesn't amount to much of any significant deficit. We've got to talk about the depth and speed of spillage. How close is that liquid getting to the airway? Okay, so the depth of spillage matters post-extubation. Residue, not just a trace amount of residue, but increasing amounts of pharyngeal residue that aren't clearing. Why does that happen? Does that happen often post-extubation? Well, it's one of my pre-PO trial initiatives looking at pharyngeal squeeze. We'll talk pharyngeal squeeze coming up in a matter of moments. It's the motor function, muscle tone involved in the swallow becomes weak. These patients that have a breathing tube between their vocal folds develop muscle disuse atrophy. We tend to see a lot of pharyngeal residue that doesn't clear, and you draw on the sensory loss component again. Many of these patients, you can talk to them, show them the screen, they say, well, I see what you're showing me, but I don't feel that in my throat. It's a profound moment post-extubation. Have a conversation with a patient with bolus increasing the molecular space, and they have no idea that it's there while they're speaking to you. Okay, now, penetration aspiration. I look at these factors in terms of the depth. How deep is that penetration going? We'll talk about some secretions rating scales that fall along those lines. Okay, where you're talking bolus or secretions, we're thinking about depth, proximity to the airway for penetration. For aspiration, I also think about depth, D-E-P-T-H. Is it just below the true vocal folds on the subglottic shelf? Has it reached the cricoid ring? Has it actually reached the tracheal rings? Am I having to cue this patient to clear out material from the subglottic space? These are all questions that help me understand severity post-extubation, okay? Poor respiratory swallow cycle coordination is something we see on a very regular basis post-extubation, particularly with chronic obstructive pulmonary disease and everything that falls under that umbrella, the chronic bronchitis patients, the patients with emphysema, those are chronic asthma. But you also have some poor respiratory swallow cycle coordination with congestive heart failure and COVID as well. Now, vocal fold dysfunction. I'm not here saying that every patient that has a vocal fold weakness has dysphagia. My own mother did. She had a small medullary stroke December 18th, 2018. She was told she had laryngitis. She had a vocal fold paresis. It was aspirating thin liquids. That's a true story. So certain vocal measures that I will look at post-extubation may help me know if someone's vocal weakness may be just a bit more than what we see on your typical post-extubation patient, where in that first couple of hours, there could be some edema, there could be some shortness of breath, but it's when these conditions linger on in the day and the follow-ups that's when we start to have some of our questions answered. Anatomical change in the airway. When the extubated patient is part of a burn unit, part of a trauma hospital, part of a head and neck cancer case, and you have any anatomical change that's affecting airway protective structures, the severity on fees is likely to be greater. Supplemental oxygen demands. I'm sure if I talk to Brooke off camera, we could probably have our own separate course about fees and high flow nasal cannula. It is the question I'm asked in all my travels. High flow does not have to mean NPO. There are certain factors associated with high flow that we'll talk about this evening that might limit what we can do. When patients are getting more liters per minute on high flow support, they tend to have other factors present. Maybe they're not quite hemodynamically stable. That has to be considered. And then for sensory, one other item, the laryngeal adductor reflex response. I'm sent reports on a regular basis from people I don't know asking for help. And people want to know, well, Eric, how can I understand sensory loss? I don't do fees with sensory testing. I'm not comfortable tapping the arytenoid cartilage. Well, here's a couple of ways. Look for reduced frequency of swallows. Listen for and look for retention of secretions during fees. And then if someone is penetrating on the verge of aspirating, do they have this brainstem controlled response, the LAR? I wrote my dissertation on this topic, that causes the arytenoids and true vocal folds to close, allowing for airway protection. These factors are not my only concerns when I'm looking at severity post-extubation going in, but they really are something constantly on my mind. The endotracheal tube is made of a polyvinyl chloride. We must be aware that this tube is not soft. I wish I was there with you right now with all of you. This tip right here, you can see at the bottom of my page right there. See, it says BEVL bevel right there. Okay, there's the bevel tip. There's your cuff, right? This is how the respiratory therapist inflates and deflates. But if you look at that bevel, holding it up right here, it's actually pretty sharp. It's actually pretty sharp. If you press it into your finger, you can actually, my finger, see it turning white? It is not soft. I can tap it on my laptop, not soft. So why fees post-extubation? And when? Well, there's a greater propensity for left-sided throat trauma during the intubation process. It is actually thought to be partially related to how these tubes are shaped. Angled to the left, believe it or not, thought to ease insertion between the true vocal folds. It might just be the technique of taping this to the left side of the mouth, which we often see. When the intubation is taking place, the practitioner may hold with the left hand, inserting from the right side, or turn to the left while the right hand while being inserted. This has been discussed going all the way back to the 1970s in the Journal of Anesthesia. The propensity for left side trauma has been also discussed by the great Dr. Martin Brodsky of Johns Hopkins, now Cleveland Clinic, that this left-sided trauma is potentially just from technique. We see this time and time and time again. Now, I'm not someone who's out here doing a feast course who says stop doing modified barium swells. I love doing modifieds too. Do lots of modified barium swells, right? So for me, post-extubation, one of the factors that I'm concerned about, a really increasing level of dysphagia or throat pain with the swallow. That's really hindering a patient. They may actually point to one side of their throat. I'm going to be able to capture mucosal tissue change, not to diagnose a dislocation or a subluxation, which is a partial dislocation, but to identify earlier on in the process so that people get properly diagnosed. And it just is a very different perspective, as you can see. Tell me how this might look to you in an MBS, lateral view. Would you get the same perspective? This is a hematoma, okay? That's a hematoma here, okay? Now, what's concerning here? Potential compromise to airway patency. That's the concern here. This large area of edema with purple discoloration is encompassing the left piriform sinus, the left arytenoid cartilage, the left aryepiglottic fold. It is actually covering our view of the true vocal folds with the exception of the anterior aspect of the right true vocal fold. Remember, if you've ever taken an intro course with me, we like to look for lollipops on a stick. The arytenoid cartilage to the aryepiglottic fold should look like a lollipop on a stick. Right side is intact, left side is not. In cases like this, we're getting called in these days earlier and earlier. Nurses, can you come in? They're going to be extubated at 10 o'clock. Can you be up here at 10 minutes before? Like, why? Well, we want you to be ready. I often ask the question, can we see if it's okay before I start them if they can breathe on their own first? They've been breathing on a machine for 2.5 weeks. Sometimes in acute care and in LTAC, there's a bit of getting your arm twisted into certain situations where you might be the first person on the scene to capture something like this. And for me, A is for airway. Airway comes first. My great friend, Fred, who trains with me, we always talk about take time to watch your patient breathe. The breathing's not going to look right here. That's not something that chin tuck and head turn left is going to solve. That needs medical management. The deeper we get into this medically complex scenario of early arrival after extubation, the more frequent these types of changes can become readily apparent. Now, We know for a functional swallow, we've got to have all cylinders firing together, neurosystem, respiratory system, gastro system. These are not harmonious during intubation. Patients are sedated, a machine's breathing for them. The sedation affects their cognition, and then you've often got either an NG tube or an OG tube to do the feeding. And then you just magically take these tubes out and think, snap your fingers, we're supposed to be fine. We've got to be concerned for muscle disuse atrophy, which for me, my friends, it doesn't always talk about the length of time someone's intubated, because patients can develop muscle disuse atrophy just even 48 to 72 hours into the process. Cough and gag reflex response may be reduced when you see them in those initial minutes post-extubation. Now, we know you don't need a functional gag to swallow. I get that. It's part of my cranial nerve assessment. But I'm certainly concerned when a cough ability is reduced and they sound like they're underwater, because many of those patients who can't expectorate into that yank hour end up getting reintubated. It is most unique that we're dealing with a population that has a temporary artificial airway. It's not going to be used as long as a tracheostomy tube is used. And a tracheal tube is not going to be used as long. Then you've got the disorientation impact. Some patients are a lot more sensitive to their medications, and it can take some time for these medications to work their way out of their system. We've got to understand when this intubation is being done. Is it a short postoperative type of airway? If it's a short post-op case with no prior neuro disease, no reflux, no head and neck cancer, with a viable airway, you're not going to see generally the same dysphagia symptoms in someone who's not very old. Now, you can take someone who's got a viable airway, who's got no neuro disease, no head and neck cancer, who's getting a short intubation for surgery, who's older, who may have a different outcome with the anesthesia. Okay. We've got to consider, was this emergent done in public, en route to the hospital, with suboptimal optics? Those things do happen. Then there's the reintubation sequence. When someone self-extubates, trust me when I tell you this, do you see this cuff right here? Let's see if I can get it. A patient is not going to ask the nurse, excuse me, I'd like a syringe so I can deflate my balloon and rip this out of my throat. That's not what they're going to do. They're going to rip this out, cuff inflated and all. And if that has to go right back in, that can be a major source of trauma to the mucosa. So it's one of the many things I look for. Has this patient ever self-extubated and been rapidly reintubated? I think this article by the great Dr. Greg Postma changed my career. I have an article that follows up on this from 2021. I like to span time on my articles, and I certainly want to know this one, which I would consider a seminal study. By that, I mean it's a foundational study that I really think people jumping into this arena of care should be aware of. Hospitalized patients with dysphagia at risk for airway deficits. Look at the percentage, 79%. This is in 2007, talking about speech and ENT, seeing patients together. Now, if you've traveled around like me and you're not been in a, again, I wish maybe I had a long career in the VA or a larger teaching hospital or a larger urban hospital where there's 1,000,001 disciplines right at your disposal. But I've been in rural central Florida hospitals. You have a better time finding a pot of gold at the end of the rainbow than an ENT. I'm not being sarcastic. I'm being honest. So I think the thought here is that whether it's you and a hospitalist, you and a pulmonologist, you and the intensivist, someone that you can rely on and say, we need to identify these disorders earlier on so we can see how it affects their breathing, their voicing, their airway patency, their swallowing. You realize something here at 8:25 p.m. Eastern time. We're doing an assessment of the aerodigestive tract. You take that finding from 2007, you fast forward it to Pazak et al. 14 years later, guess what their percentage was? 79% laryngeal findings. It's still the same in 2025. Trust me on that. Whether you're talking lesions here, vocal fold paresis here, or edema, granuloma, or you're fast forwarding to 2021, talking about lesion, edema, erythema, we're seeing the same things over many, many years. 25 years doing fees, this is not changing. Technique of intubation is not changing. And you say, well, can't they see where they're going? Yes, they can. They can see where they're going when they intubate. If you're not familiar with the term erythema, that's a term we utilize for redness, just in case you're not familiar with that term. We don't have control of when this breathing tube is being removed. Is it being done at the end of inspiration when the glottis is fully open? We don't have control of that. It's a great thought, but that's something that is handled by respiratory therapy. Okay, and then there's issues with the cuff, failure to deflate, the tube not being managed properly when patients are being cleaned and turned. The leak test. If you want to say to me, Eric, what is something that I may not read a lot about in a fees or dysphagia book that I should know about? Leak test results. And it might be written under procedures and the medical record. A leak test is done to deflate air from the cuff of the endotracheal tube. The RT is supposed to report back to the doctor as to whether or not there's airflow coming up from the subglottic below the vocal folds to the supraglottic above to that space, right? What a great idea. Let's see if they can breathe before we take this out. Some RTs I've worked with very close to will tell me, well, you know what? In my experience, if there's a weak leak test result, I don't hear a lot of airflow, it's usually just edema. So I'll tell the doctor to extubate them anyway. We'll give them a steroid and then they'll be fine. It's not always the case. If I had a dime in my pocket for every set of vocal folds I came across that weren't opening properly, or granulomas blocking the airway post-extubation that ultimately led to patients getting re-intubated, not on something I did wrong, but on what we were seeing, I would have a lot of dimes in my pocket. It's not always well documented either. Sometimes I do have to ask for that information. The size of the tube. There's some research out there that suggests that shorter people should have a smaller size endotracheal tube for smaller anatomy. Okay? Generally speaking, male patients have a larger trachea than female. Some of the research has gone on to discuss that the size of the endotracheal tube may be a factor in post-extubation dysphagia as well. We're going to touch on that by some of the great research of Dr. Emily Plowman coming up shortly. So there are some things to consider well besides length of intubation, and I'm highlighting some of them here. This is their image orientation. This is a term we should know. Our image orientation is flipped with the epiglottis at the bottom of the screen. When they go to intubate, left is left, right is right. Look at the first point of contact, my friends, left arytenoid cartilage. This is with the Karl Storrs monitor, and I don't work for them, but I've used that monitor for fees thousands of times at CMAC. It's a pretty clear view, right? I don't work for any endoscope company, but I'm just saying, clearly being able to see first point of contact, left arytenoid cartilage, second point of contact, left arytenoid cartilage. It's not like I chose this to bias you. It's what it is. Then the contact gets very close to the epiglottic rim, often lifting it up. And then if you're not familiar, when someone's intubated, the endotracheal tube sits right here near the posterior commissure. That's where it should be. But just on technique, it's that first point of contact is the left side. So we've got to understand this cuff being inflated here, it's going to stop all that airflow, just like it will with a trach patient. But this is even more critical because this tube is in the mouth between the two vocal folds. These patients are going to have numbing agents applied. They're going to be sedated to block the hemodynamic reactions. Imagine if everyone intubated wasn't ever sedated. They would have everyone in the world be having laryngospasms. So there's certain medications being given here to calm patients down for this process. But once that cuff's inflated, there should not be airflow coming up to allow for voicing. So it's separating the upper lower airway. Now, is that blocking of airflow a contributing factor to sensory loss? Maybe short-term or longer-term. I think it's certainly possible, similar to that moment with a trach patient where we deflate the cuff and hear that cough for the first time. Obviously, this tube is manually placed in the mouth. So then you have to consider whether they're using the Macintosh or Miller blade. We don't have any control over that. They are trying to get their airway view. You probably heard this on ER or Grey's Anatomy when they yell out, "Okay, I see the cords," and they go to intubate. But when they're using a Macintosh or Miller blade, they being the medical practitioner, guess what they're doing? They're invading our territory, my friends. They're raising the epiglottis. They're placing this device in the vallecula. They're lifting the epiglottis. They're manipulating structures to get a better view of the vocal folds, because their job is not voice and swallow therapy in Austin, Texas, or outpatient swallow therapy in Burlington, Vermont. Their goal is to get and establish an airway. So these are some of the things that we might be seeing post extubation. I would document this as the patient presents with an adhesion-like appearance going across the posterior commissure, an adhesion-like appearance across the posterior commissure. This looks like someone took a piece of their mucosa from another part of the body and almost glued it here. Obviously, that's not what happened. But this is not compromising airway patency, meaning it's not blocking their airway here. I can see multiple tracheal rings. And if you're keeping score, there's greater erythema here on the anatomical left side compared to the right side. Please note, this type of trauma is not the same edema we see related to acid reflux, which is another course for another day. But not all changes at the posterior commissure are secondary to acid reflux. That's something important for us to know. Now, this image is flipped here on the left side, so left is left and right is right. These are swollen arytenoid cartilage. They have almost an irregular contour to them here on the left side and the right side, and it's really hard to see any vision of the vocal folds here whatsoever. You can see greater erythema, redness on the epiglottic rim here, with maybe a small cyst developing there from potential contact. Now I bring you down to the bottom of the screen, which is posterior in this view. So here's the posterior pharyngeal wall region, right? Here's anterior, because we're flipped. See these wrinkled appearance here to the post-cricoid region? This mucosal indentation, as I like to call it, at the post-cricoid region is often a byproduct of prolonged or traumatic NG tube placement, prolonged use, traumatic placement, or multiple NG tube placements, or long-standing reflux. One of those factors is giving us this mucosal indentation here. Now, this image is on an angle, so to orient you, here's the anatomical right, here's the anatomical left. You can see a little bit of erythema here on the left side, not as much on the right side. This is the posterior 1/3 of the left true vocal fold. Again, that sweet spot for the ET tube sitting right here. So this to me would be documented as an ulcerative-like appearance that is tan and smooth in appearance, that is moderate in size, that is at the posterior 1/3 of the left true vocal fold and extending into the subglottic space. For point of reference, if it's me treating the patient and I'm seeing this, I'm seeing this, I'm seeing this, or this, I'm referring to a medical professional in that setting who can address difficult airways. And that is not always going to be an ENT. I've had some of my best support in these scenarios, inpatient-wise, actually from pulmonologists in all of my travels. So we've got to know when to wait to get that consult rolling and not just put in our notes, oh, consider ENT follow-up when possible. Or one of those things they like to do and say, oh, can't they just come back as an outpatient? We, as Dr. Postman puts it, need to get some of these issues addressed earlier on before they become much bigger problems. One of the things that we often have access to in the medical record, one of my favorite things to look for in some of my hospitals, they have this under procedures, is the Cormack and Lehane scale. This is a scale that's used by medical practitioners to really gauge the openness of the airway. So, Cormack and Lehane grade 1, the glottis is completely visible. Generally speaking, it's going to be easier to get an endotracheal tube into this space. It's going to be an easier fees exam most of the time. Now, I've had a lot of people out there, a lot of people tell me, Eric, it's not important to document on the resting position of the epiglottis. I think it is. I follow Cormack and Lehane. Take a look at the difference from here to here. You tell me. Would you rather be dealing with an airway like this versus this for your exam? Yes, we can do an exam with an epiglottic rim like this that's elevated off the base of the tongue surface. We're going to have to do our deep dives up and over that epiglottic rim to get our view. But guess what they'll be doing to get this breathing tube in grade 3 or grade 4? Guess what they'll be doing more of here and here? Grade 1, grade 2, maybe not. But grade 3 and grade 4, more mucosal contact to get this tube right there. So if I get a into the medical chart, Cormack and Lehane grade 4, difficult airway, multiple intubation attempts, in my mind, I'm thinking this is what I'm going to see. It matters to me a great deal. I think it matters to me in a separate topic about NG2 placement as well. Different topic. Let's just pause. I'm not saying we're putting an NG tube here. Not what I'm saying. I'm saying for an NG tube that goes here, when there's reduced posterior to anterior space in that airway, an NG tube placement can be difficult as well going here. When there's reduced spacing posterior to anterior, an endotracheal tube getting to this point be a lot more of a challenge as well. The anatomical influence on the bolus, the anatomical influence on the endotracheal tube placement. More space, generally easier to place. Think about an NG tube going here. Less posterior to anterior space, more potential contact with structures as well. Separate tube going into the GI system, but think about reduced spacing. Now, we're talking about the endotracheal tube here going into the airway. If I get reports that it's grade 3 or grade 4, Cormack and Lehane, I may also look for one additional item in that note. Is there documentation of that patient having an anterior larynx? What does that mean when the note says the patient has an anterior larynx? That means that these structures right here that I'm circling, right there, in these first two photos, this anterior commissure region appears unreachable or anterior to the line of sight. So you're pretty certain that if they're Cormack and Lehane grade 3 or grade 4, there's going to be more manipulation of that airway to get that breathing tube through here. These are some areas that I don't hear as widely publicized in our medical chart review. But trust me when I tell you, I've never stopped seeing patients in 27 years. Case history should not be a mystery. I will do a deep dive and I will look for those procedure notes to get me this information so I can try to help myself know what I'm about to be getting into. And then there's the research. We do base our clinical decisions on what we've learned, what we've seen, what we've been told, the setting that we're in, the medical acuity of the patient, what the patient and the family want, and then the research. It's just one big accumulation of information. In the Lynch article here, it's important to note that these patients were intubated greater than 24 hours. It's important that you know there was no prior dysphagia, had neck cancer, no known neurologic disease. Now, could there have been dysphagia that was not known? That's always possible in any of these studies. That's always possible. 44% of these patients in this study had an endotracheal tube size of 7.5 or smaller. In this cohort of patients, 5 of them aspirated ice, right? 9 aspirated thin liquids, 2 of them aspirated with puree, 4 of them aspirated with mildly thick liquids, and 1 with solid. But here's the issue. 14% of those who aspirated on fees had no signs in the clinical exam. You know what we call that? The false negative rate. The clinical bedside swallow evaluation in medically complex patients fails to identify disorders. Failure of a test to identify a disorder is the false negative rate. 23% of those who aspirated on fees pass a 3-ounce water swallow. And then there's those who had recommendations for regular diets who ended up aspirating during fees. So are we doing enough? Maybe not. Could we be doing more? Sure. Maybe we have to justify for more equipment, more training, more staffing. You've seen what I've seen, and you can laugh. Patients sometimes walking faster than the physical therapist around the nursing unit. They're outpacing the PT. Does every patient need PT? It makes you wonder, if you are surviving acute respiratory failure and you're in the know as a patient and you've done your research, do you want a test that's variable accuracy? Or do you want a test like fees that has more precision? It's not about being fearful. It's about being aware of what we miss. So you take the work of Marvin et al. And we think to ourselves here, my goodness, how many times this week, in the past 10 days, have I gotten called in sooner and sooner and sooner post-extubation in LTAC and acute care? And you know, it's the scenarios where there's an OG tube. A lot of the time, they'll pull the orogastric tube, they'll pull the endotracheal tube, and they'll say, okay, what about the PO meds? And the doctor goes, oh, try it with pudding. You would never hear a patient who's laying in bed for 2 weeks intubated, you'll never hear the doctor say, oh, go ahead and let them ambulate to the bathroom by themselves. It's a good idea. There's incident reports for that. There's alarms for patients who might move out of the bed, not yelling at you, but where's the alarm for the patients who are silently aspirating? Well, there isn't one. We've got to be aware. Maybe even more aware. Maybe you can get more information out to your teams after tonight. Maybe something here triggers you, right? But Marvin et al. Says, yeah, we can manage patients the same day of extubation, but maybe the dietary restrictions are going to be greater. Maybe there's more aspiration. But if we wait that dreaded 24 hours, oh my goodness, can you imagine waiting? Maybe less dietary restriction and maybe more normalized PO diets and maybe less aspiration, which is what we all want. QOL, quality of life. And I'm a quality of life person. I've had dementia, cancer, autism, hearing loss, reflux in my family. I'm going to bat for family members the way I go to bat for patients. But we don't always have the time to wait. Going back when I started in hospitals 26 years ago, these days they want them out of the hospital before they're even in the hospital in many scenarios. So I think Madison Mock, Dr. Madison Mock, a critical care pulmonologist, really has something here. I think that the thought should be, get speech a bigger seat at that decision-making table. And I'm so pleased to see, as part of my job doing fees competency in 2 states right now, in 7 hospitals, more and more SLPs being asked to come to rounds in the LTAC, in the ICU, in the burn unit, to get that voice. And you hear rounds happening when an SLP is not there. Someone goes, how are they doing? They're swallowing up. I didn't hear any coughing. I think they're okay. That's about the extent of it. because our work is so covert. It's all inside. So let speech decide if you can advance a diet post-extubation. Let speech decide if instrumentation is needed. Let speech decide if the patient maybe needs to stay NPO and reassess in the future. Let speech have a bigger say in these post-extubation cases versus just one way. I mean, when I got to Ohio, to be respectful, I was told by the pulmonologist first day of work, we don't need any of those fancy swallow x-rays. Just do your clinical exam and tell us what you think. That was in 2016. That's something very real that happened to me. So is it necessary to wait 24 hours? Some sites have that as part of their policy and procedure, and some sites don't. The end game of fees after extubation, timing is everything, is really going to be, it's very patient specific. That's what this all boils down to. And the research that I'm pulling here for you tonight goes on to further that point by some of these top researchers in healthcare, not alone in our field, but in healthcare, right? In this study by Leader and company, there was no known prior dysphagia. There was one intubation. These patients had adequate neurostatus, right? And they indicated that when the Yale swallow protocol was passed, that you could recommend a PO diet without an instrumental as soon as 1 hour post extubation. I do agree with their thought in this study that the idea of prolonged intubation has a wide variety of definitions. And certainly tonight, I've been going at it now 47 minutes. We're not just talking about length of time, which is a very popular topic. There's a variety of other factors tonight that I do have to consider that I've mentioned. So in that world that you work, maybe you're in Omaha tonight, maybe you're in Nova Scotia, maybe you're in Miami. Thanks for being here. But where is your world? You see what I'm saying? Look at the results, but find your world. Yes, it worked here. But look what's different. Intubation equal to or greater than 4 days was significantly linked with non-functional swallowing. So if you want to take every article you look at, which people do, and say that works for me, that's going to work for me all the time, maybe not moving so quick if this is your world, because that's my world. I don't get the easy short intubation duration patients. So that's something here, not to be negative, but to be realistic. To be realistic. I am an eternal optimist. I teach 12-hour courses on my feet for 14 hours. I get people their passes. But I'm telling you, I've got to look at every dot, every sentence in these articles to say, what will work for me? What is applicable for that patient? So I already told you what Dr. Postma said in 2007. He said that speech and ENT should be seeing patients together. I already brought you the research from Pazak in 2021. Those authors both said, guess what? They both said 79%. Well, here's T.D. et al. In 2010. So we're almost right in the middle. I'll give you 2007, 2010, 2021. Look at their percentage of laryngeal change, 73%. 3 articles over the span of 14 years, all 70+% laryngeal change. So one of my main questions when I go in is not only how long was Mrs. Smith intubated, it was how was her leak test result? Was it a difficult airway? Were there multiple intubation attempts on a single intubation? And the biggest question of all that decides what I'm going to be doing for that short while is this patient who the nurse is calling me off the hook to come up, are they a prime candidate for reintubation? It's not the only article that says this. Those that have granulomas large enough to block the airway, those patients who can A-B duct and open up those true vocal folds, we think we're going to jump right in there, get them on our favorite IDSI level, put a t-shirt on them that says, Chin Tuck saves the world, not so fast. We might walk in and ask that question and get the answer I've heard at least 200 times in my career. Eric, you know what? I'm glad you came to me first. I didn't even have time to chart yet. The ABG just came out. We're going to reintubate this patient. Or their striders post-extubation, we're on the verge of reintubating them. So just hold off. But it takes communication. Because what you think might be written in an order at 8 a.m., trust me, at 9:30 in LTAC or acute, that might be very different. Very, very different. So I'm looking at my patient's post-extubation. I assume some levels of altered mental status may not be off the charts, but a dementia patient who's had hip fracture surgery, getting anesthesia for the first time in 25 years, their AMS post-extubation may be profoundly different. And they may never get back to the baseline ever again. That's what happened to my own mother-in-law with dementia. Medical examiner's case. Hip fracture surgery, September 2024, died December 2024. So you hope to see a bounce back to that traditional, maybe mild confusion. Not every patient gets there. A common finding on fees, edema in the throat, does not always persist. Throat-based reflux can be exacerbated during intubation because of the use of tube feeding. LPRD is laryngopharyngeal reflux disease. It can be worse because of tube feeding, because they're laying flat in bed. Maybe getting tube feeding for the first time in their life. An NG tube is partially stenting the UES open. Okay, muscle weakness, muscle disuse atrophy, weakened pharyngeal squeeze. Sensory loss, whether you're doing air pulse sensory testing with fees plus ST, fees with sensory testing, or you're looking at reduced frequency of swallows, poor management of secretions, and weakness to laryngeal adductor reflex. There are other ways to look at sensory loss. Okay. As far as phonation weakness, sometimes we see that rapidly improve. Some people may use easy to use items like Dr. Jamie Kaufman and the glottic closure index, asking patients questions if speaking is taking extra effort, throat pain or discomfort with voicing, worsening vocal fatigue, cracks to like pitch breaks and cracks to the vocal quality. Okay, the glottic closure index, a score of 8 or greater, may be suggestive of someone whose vocal folds aren't fully coming together. Could be an issue that I talk about in my clinical exam. I don't say that vocal weakness automatically equals paralysis or paresis. There are other factors there, like diplophonia type quality. Okay, so we may hear some vocal weakness that rapidly improves. We may see that start to persist. That's something very different. Okay, and I have some patients who tell me it feels like the tube is still in my throat. And I say, wow, you know what? I'm actually glad you told me that because it lets me know you're feeling something. Some patients feel that tube sensation like it's still there. They'll tell you my throat hurts when I swallow that odynophagia. It's not an altogether bad thing to have some feeling there. Not a bad thing at all. Okay, so I've got to look at the respiratory rates. Is it a rapid respiratory rate post-extubation? Is there greater respiratory effort? Is there presence of prior pulmonary disease, such as COPD, where there's a coughing, breathlessness, and secretions production beyond the normal day-to-day? Why do I bring up COPD and prior pulmonary disease? Because they have a huge umbrella of conditions under that, including chronic bronchitis, emphysema, bronchiectasis. And when those patients go into exacerbation of COPD, they may be a prime candidate to get intubated, and that may be happening on a regular basis. I'm saying a couple of times a year. Okay, some of those same patients with COPD may have significant presence of sensory loss in their throats. The impact of neurologic status. Are they awake and alert enough to even participate? What is their respiratory pattern? Is there effort to their breathing? Is there documentation on rhonchi? Patient presents with scattered rhonchi and the upper airway that doesn't clear with acute cough. You know, when I read a pulmonary note that says patient presents with scattered rhonchi and the upper airway that does not clear on acute cough, those are the patients who are gurgling. Then the arterial blood gas, ABG, objective data. One of the areas we know very well, O2 saturation, tells us how well the oxygen is moving in the blood. One of my key ABG factors, and again, it's not a lab course, but I've got to mention it here. You read the research from Tartar et al. In 2017. Normal pH level 7.35 to 7.45 on an ABG. 7.35, 7.45. If you're seeing a patient with a low pH level below 7.35, that's acidosis. The body cannot remove carbon dioxide fast enough. There is a plethora of research out there and clinical exposure. Low ABG for pH level, low pH level on ABG. That was a Freudian slip. Low pH level on ABG post-extubation, talk to respiratory first. That may be something in line with someone who's about to get reintubated. The X-ray, is it show that the lungs are improving, or is there atelectasis with lung collapse? Is there whiteout in the lungs caused by pleural effusion, where there's fluid between the lung and the chest wall? Is there atelectasis because of mucus plugging? Some patients may need an emergent bronchoscopy post-extubation to clear mucus plugging. They're not ready for us. Supplemental oxygen support, got to think about high flow nasal cannula. Key element here on my FEES exams on high flow, can I get around the nasal prongs with the scope that I have and the configuration of their nose? That's a significant factor. I need to be able to see some dark space when I go to look up there with my scope. That's one of the key factors to high flow. And then talking to pulmonary and say, hey, if my scope is in this person's nose for 10, 11 minutes, am I blocking the actual intended effect of the high flow getting in? Something relevant to ask. Okay, look at patient's color. Are they looking pale, blue? Are they diaphoretic when I arrive? Is there concern for aspiration from reflux and secretions? Are they gurgling and having tube feeding present? And you can even smell the tube feeding on their breath. And then strength of cough. One of my key elements for these patients, I like to see what they can do spontaneously and on command. Can they expectorate into an oral yank out resuction? Okay, I talked about laryngeal adductor reflex. This is sensory based. It's one of the factors I look at in my FEES assessments. Post-extubation, certainly. We're talking about when that sensory nerve for the throat, the internal branch superior laryngeal nerve, when that is stimulated, is there an airway protection response before that person ends up aspirating? That's what the LAR is about, laryngeal adductor reflex. It's why some of those patients can penetrate deep to the true vocal folds and end up protecting the airway, and some of them cannot. A lot of that has to do with the laryngeal adductor reflex. It's one of the key elements. Brainstem control response that I look for sensory perception with my patients. Pharyngeal squeeze, this is motor. Pharyngeal squeeze, we're talking muscle tone. We're talking pharyngeal constrictor muscles. We're talking motor function. We're talking vagus nerve territory. You know what else we're talking about vagus nerve territory? LAR, okay? The sensory here, the motor here. Whether you look at the research from Dr. Perlman and the ENT group out on Long Island, or the great Dr. Anna Miles, who developed the New Zealand secretion scale, you're talking over 20 years of research. Weak pharyngeal squeeze, high correlation with post-swallow bolus residue in the pharynx, pH pharynx, with greater risk potential for penetration aspiration and, not surprisingly, greater retention of secretions. What we're looking for in pharyngeal squeeze is the left lateral pharyngeal wall, the right lateral pharyngeal wall to move medial. I like to call the left lateral pharyngeal wall 3 o'clock, the right lateral pharyngeal wall 9 o'clock, and then right here, the posterior pharyngeal wall, I like to call that 12 o'clock. I'm looking for this arch, ARCH, right here, to tell me about motor function for that swallow. Try to have my patient produce a strong E sound. And I'm looking for approximation here, curvature and contraction here, approximation here. Look at the space difference on this photo on the left side of your screen. Look at the space that's there, space that's here. Posterior wall is more flat. This is not a pharyngeal squeeze. This side is. Points of contact and approximation. 1, 2, 3. Curvature and contraction, approximation, approximation. What is the best time to capture pharyngeal squeeze information like this? On fees, just before or just after whiteout, one of the best times to slow my video down to get that information without a shadow of a doubt. Not always going to be the same. We may have one side that is stronger than the other with pharyngeal squeeze. Here, the left side, lateral pharyngeal wall showing greater medial movement comparatively to the right side. That happens all the time. It's not surprising to see more bolus and secretions here on the anatomical right side, where there's no medial movement of that lateral pharyngeal wall. Big sample sizes are something that I like. I like big sample sizes when they're available, right? The Apache, acute physiologic assessment and chronic health evaluation. Acute physiologic assessment and chronic health evaluation. 0 is minimum, 71 is the max. Trust me, it's not like school. You don't want a higher grade here. Not good. Okay, you'll see what makes it to this list. You've heard the things I've been talking about tonight. You'll even see some of the things that were my first page talking, one of my first pages talking about severity. Poor secretions management. We talked about sensor loss. Prolonged weaning is the same as prolonged ventilation. Prolonged weaning is going to make you on the ventilator for more time. Your lungs become dependent on that ventilator. We have COPD that made it to that list. Talked about COPD earlier. The alveoli become destroyed in those patients' lungs. We talked airway patency problems. I've shown you a couple of photos of this already. It's not out of the realm of possibility for me to be talking to the nurse about a potential compromise to airway patency. You have heart failure added to this list. Many patients, not all with heart failure, have a shorter lifespan. Okay, heart failure may impact the lung mechanics because of increasing congestion. You may also have patients with heart failure with increased actual size of their heart, which can actually cause airway obstruction and actually cause some restriction in lung movements. Okay, you've got elevated BMI in here too, increased intra-abdominal air pressure, and may cause muscle failure. A lot of patients with increased, elevated body mass index also have worsening acid reflux as well. Any of those factors is a highly influential component as to when and how I might be working with that patient post-extubation. And then there's the secretions, which is on that list, was on my list of severity earlier on. Anna Miles, her work is fantastic. I mean, just a dynamite person to even message to talk about her research. And I'm grateful for her and the other researchers that have taken the time to respond to me. Sample size is fantastic. Why is this study so important to me? And you may say, oh, he has all these scales. Should we be using all these scales? I'll tell you right now, we've got about 26 minutes left. I think it's most important you understand the science behind these scales. Choose which ones you like, but know the science here. What is the critical component here? More patients in this cohort silently aspirating secretions than food and liquid. That's profound. That's a significant statement because these patients can develop pneumonia regardless of their PO intake. The New Zealand scale maxes out at 7. We know PAS, Penetration Aspiration Scale, 1996, Dr. Rosenbeck, levels 6, 7, and 8 are the aspiration levels for food and drink on the PAS. Something separate. So it's not surprising that the PAS scores greater than 5, i.e. 6, 7, and 8, the aspiration levels, and the New Zealand scale, if it's out of 7 and you're greater than 4, I'm not surprised those patients develop pneumonia, but it's the 11% who develop pneumonia, even though they're not aspirating food and liquid, they're aspirating on their secretions. We're talking about location, amount, and response to retained secretions. So just understand something very important here. Though all the singular scores are zeros, ones, and twos, the only singular score that gets a 3, no response to secretions in the laryngeal vestibule. So, does penetration of secretions as a standalone finding matter here? As a pneumonia risk predictor? Yes. See that score of 3? Guess who else gave it that score? Dr. Joe Murray, the only person who would mentor me back in 2008 to get my BCS when there were no mentors. 17 years ago, he helped develop FEES and its protocols. He developed the very first secretions rating scale in 1996 that's wildly popular. And the same score for the same condition was given by him back well before this scale came out in 2017, 21 years before. So it's not changing. Like I told you, from POSTMA in 07 to PASAC, and that laryngeal changes from intubation aren't changing over 14 years, you're talking 21 years, 2 different researchers giving the same finding, the same exact score. That's relevant to our work now. And I love the work of Dr. Pasigna at BU, who took over some of the research duties for Dr. Langmore, messaged her as well. I love this ice chip protocol. I use it during FEES all the time. 1/2 to 2 ice chips in properly selected patients to try to help reinvigorate the swallow mechanism for patients with retaining secretions who maybe aren't trying to clear so well on their own. Not the world's greatest sample size, but some percentage of patients did have secretions management improved with the use of ice chips, not randomly being given, but 1/2 to 2 ice chips in 3 repeat trials for NPO patients. And at the end of those 3 trials, you decide, is the patient looking worse? Are they starting to get better? Are they substantially better? If those 3 trials, and I like to do 2 chips per trial, honestly, but if they're doing better after 3 trials in their NPO post-extubation, that's a green light for me, clinically and research-based, to say, let's move on to the PO trials for the NPO patient. But if I do 3 trials of ice chips, 2 chips, and I'm using that with food color, my food coloring, by the way, and I'm seeing this person getting worse full ice chips, going into laryngeal vestibule, aspirating, not coughing, I may say, you know what, this person's not ready. And I do have to be that person sometimes to mention that information. Now, her research in 2018 goes back to the scale, probably my favorite secretion scale, by Dr. Donzelli, a medical doctor, and his speech team developed the Marion Joy 5-point scale. Why do I like the scale? Developed by a medical doctor and group of SLPs. I worked trach vent FEES team, Miami, Florida, for 14 years. I worked for a year at Columbia on an ENT FEES team. So I know what it's like to get doctors to buy in, but I also know what it's like when doctors don't want speech in the building. I've been there too. But the medical doctor and speech team said, let's call secretions retention in the larynx above the true vocal folds as a severe deficit. We're going to change the definition here. Anything at the true vocal folds or below, they're calling that profound. Can you imagine? They're saying in this scale that if you're deep penetrating to the true vocal folds or aspirating, from a secretions perspective, it's the same level of severity. That's very interesting. In the scale that Dr. Donzelli and his speech team developed, 86% of the patients who had profound secretions management deficits still needed some form of non-oral intake due to the severity of their dysphagia. When Dr. Donzelli and his speech team made this scale, the average patient who was not aspirating food and liquid had a secretions retention score of 2, mild. The average patient who was aspirating food and liquid had an average secretions retention score 3.71. It just goes on and on and on. Never really changes. Now, high flow. High flow is widely used, and for some people, it really became something they saw for the first time during COVID a lot of us with exposure. I worked with COPD patients in my LTAC and in Ohio almost extensively. So we've seen a lot of high flow. It's heated and humidified. It's giving more support to these patients than traditional nasal cannula can provide, essentially, right? So high flow can help create PEEP, positive end, expiratory pressure, the volume of gas remaining in the lungs at the end of the expiratory phase, okay? High flow is providing FiO2, fraction of inspired oxygen, anywhere from 21% to 100%. But it's the flow that's a significant difference. That's 60 liters a minute flow at the top. That's something significant. Okay, we're going to talk about dead space, about the alveolar ventilation coming up here in just a matter of moments. Okay, so one of the brands that I used almost extensively, not used, that was being used, my patients from about 2016 to 2020 was Vapotherm. Vapotherm is an increased velocity, high flow nasal cannula. It's a great tool to use because the nasal cannula prongs are much smaller, similar to the size of a traditional nasal cannula, and they're very easy to get around with a scope. The key here is this anatomical dead space. If you clear the upper airways of expired air, reducing dead space, you're making breathing more efficient. It's helping the alveoli stay open, that important site of gas exchange. High flow does not have to mean NPO. High flow, we need to consider it post-extubation. Where is our patient going? From post-extubation to high flow to regular nasal cannula, or post-extubation to large volume of high flow and maybe getting reintubated? Where are they on that trajectory? Umagari looked at high flow with healthy adults and looked at flow rates from 0 to 50 liters a minute, doing a 3-ounce milliliter water swallow, pardon me, a 30 milliliter water swallow and repetitive saliva swallow test. Normal patients, 9 out of 30, choking on high flow at 10, 40, 50 liters a minute with the 30 milliliter water swallow. Greater swallowing effort at flow rates equal to or greater than 20 liters a minute. Flow rates equal to or greater than 20 liters a minute, resulting in lower number of swallows during repetitive saliva swallow tests. What is their suggestion when looking at healthy volunteers? Maybe, just maybe, all patients on high flow, especially those at risk for dysphagia, should be seen for a swallow assessment. I'm in full agreement. You talk about patients getting seen for PT, for pulmonary rehab and energy conservation, looking at endurance and stamina. We have it right here in front of us. Are we getting this in front of the people who need to know? Now, Dr. Leader, 50 adult patients in the ICU on high flow, a portion of the remained NPO, their respiratory status impacted their ability to be tested. We get into some of those scenarios on high flow where the respiratory rate is increased, the high flow liters per minute is increased, the heart rate is increased, where medically they're so fragile that they're not really a candidate for us to do invasive testing with. That does happen. Okay, and he looked at rates of 10 to 50 liters a minute. Now, Gaelic et al., 29 healthy adults with MBS, and this to me is one of the more intriguing studies. When these patients, healthy volunteers in Gaelic et al., reached rates of 50, 55, and 60, which is the top tier when you're talking liters per minute, they did show something. Reduced predictable duration of laryngeal closure in healthy adults. You know what healthy adults can do? They can compensate. If that's your dysphagia patient, and high flow is designed to do the polar opposite of what we want, high flow stenting the airway open, we want it to close. Is it really creating for our patients post-extubation just the ultimate irony? They need this to breathe. They need food to nourish them. They need liquid to hydrate them. We've got to be able to step in and say, this works, or this isn't working yet. Maybe we'll reassess in 24 to 48 hours. There are cases and studies by Jaffe et al. Where they show high flow being reduced over the span of a couple of days with MBS and patients improving. Now, is it time post-extubation that helps with improvement? Or is it the reduced reliance on high flow? That's a very valid question. Great work by Dr. Plowman. 3-ounce water test, post-cardiac surgery. I've spent a large portion of my career doing fees, many weekends in Florida and acute care doing fees with patients just like this. 196 is a good sample size. These were not emergent procedures, and these patients were not on high flow, which I think is important to mention. We're kind of shifting gears here a little bit, but the age is important to mention, 18 to 90, because Dr. Aviv, my friend and mentor, started teaching me about age-related sensory changes in the throat back 25 years ago. So it's conceivable that sensory loss in the throat may be more prevalent in an aging population. Within 72 hours of extubation, these patients were seen with 3-ounce water mist classified aspiration. So is it a standalone valid screening tool in that acute 72-hour post-op time frame? We better be sure what we're doing in those moments, like when my father-in-law had cardiac surgery, when the patients are at their most fragile. So Dr. Robert Cameron, a cardiac surgeon at UCLA, has kind of reviewed some of Dr. Plowman's work and taking into account several other factors that we must consider. Heart failure, I've mentioned it already. I talked about that on my Apache slide. Repeat operations, why would that be important? More intubations. We talked about size of endotracheal tube, larger endotracheal tube size, potentially more dysphagia. Prolonged intubation means what? Prolonged time on the ventilator. And then the TEE procedure, more manipulation of the aerodigestive tract. Dr. Cameron's not the only doctor out there that says fees should be used more routinely post-op, not because it's basic routine, but it should be as routine as an X-ray post-extubation. That's what he's saying. That's what they're talking about. That we have something so important that we could do. Because surgeons don't want poor surgical outcomes, right? We need more to buy into what doctors like that are saying. We see patients that are too soon. Nurse calls you up. Can you come up here with your fees equipment? Quick. I've got them off of the BiPAP. And you get back up there. They were on nasal cannula for 5 minutes, back on the BiPAP mask. Patients have got to be able to tolerate nasal cannula, whether it's regular flow or high flow. 5 minutes off of BiPAP does not a fees exam make. You can't go through a mask. Venti mask, non-rebreather BiPAP, you can't go through it. So some exams are done too soon. Patients more medically fragile, and they could have respiratory distress. It's very possible. You may have greater variability to heart rate, blood pressure in those initial moments post-extubation in my clinical world and in the clinical worlds I've shared with many others. And then you have the false positive. Well, they look this way 1 hour after extubation, then they get put on this PO diet, right? This restricted PO diet, and then speech goes to follow up the next day. The patient's in MRI, they're at CT scan, the next day they're being cleaned, the next day they're at PT, then they're off for an ultrasound, you go back, and then they're discharged. That's why our notes in acute care and long-term acute care post-extubation must say patient should receive repeat instrumental swallow assessment at the next level of care, so that when we in LTAC and acute are sometimes being asked to see patients on their absolute worst days, we don't have someone who stays on that consistency until the end of time. That's something important for us to consider. Let's think about what else Sol talks about. These patients have no pre-intubation dysphagia, no stroke, no neurodisease, 65 and older. Look who makes it to the list. some patients with COPD, some with pneumonia. Decent sample size, take into account intubated for at least 2 days. More than half were aspirating, 36% were silently aspirating. What is the conclusion? We should carefully take all of this data from the leak test to the Cormack and Lehane scale, to the pre-existing dysphagia, to the length of intubation, to the presence of multiple intubations, to the people who have difficult airways, who are self-extubating, and all the conditions present, such as heart failure, and try our best to advocate for fees post-extubation, which I've done in skilled nursing, where I work too, so many times, because they never got seen for an instrumental in acute care. But if we advocate post-extubation in acute, LTAC, acute rehab, skilled nursing, or even outpatient, fall through the cracks, we can help reduce this false negative rate, which is failure of the clinical exam to identify a disorder. There are so many factors here tonight that I have to take into account to know when is the right time for my patient to do fees. I've highlighted some of the main areas that I most focus on in making that decision. Certainly, I could talk more on this topic, but for tonight, for the areas that I mentioned that you're using already, that's awesome. If there's something new here and you'd like to have more questions about it, I'm more than happy to help you any point in time. So thank you, Brooke and Tim's. I enjoy this topic, passionate about it. Really appreciate the opportunity. Thank you.
Wonderful presentation, as always, Dr. Blicker. We do have several questions, so I will go ahead and dive into them.
All right.
The first question is regarding...
I'll do my best.
The first question is regarding post-extubation edema. So the question is, in regards to post-extubation edema impacting swallow function, is there anything that the SLP can do to help support reduction in swelling, and how long can we anticipate edema following extubation to be present?
Edema may start to dissipate in someone who's had non-traumatic endotracheal tube placement. It could be a more mild reaction to the presence of a ET tube, and I'll say in the NG tube or the OG tube. If we're going in and we're seeing edema on that initial fees, and it's not something that's granuloma or ulcerative, there are discussions that could be made about contributing factors to edema, such as short-term use of proton pump inhibitors, if it's a reflux-related edema that's contributing. Some doctors, not all, may attempt steroid if they think that that short-term action could help patients out in the long run. We tend to go less with those routes when they're the hematomas that you saw that are going to take longer. So I brought that hematoma photo for a reason. But there are many patients whose edema begins to resolve that day. My spouse had breast cancer surgery in March 2023, and she had a dysphagia after having surgery at the Mayo Clinic, and has a difficult airway, and wanted a burger on the way home. I had to drive from Jacksonville to Naples, walking every hour to make sure she didn't have clots. And gradually, from that 6-hour drive, the voice came back, the dysphagia weaned off, and we started off with ice chips at the 7-Eleven and got to Culver's and got her a cheeseburger. So for her in the car, things did improve rather quickly, even though it was a short duration. That was only a 90-minute intubation, but it's a known difficult airway. I don't know if they asked her. I'm really not sure. So sometimes things can improve over a few hours. It's when you see things not improving or getting worse that may be more involved.
Definitely. I know with patients that I see with head and neck cancer, I always recommend that they tell providers at future procedures about their airways.
Yeah. I mean, and that's a whole nother segment to get into, head and neck cancer patients, different rating scales for edema, whole different cause for edema altogether. But we do have some of those patients who I was seeing post-extubation dysphagia as well, who may have had edema prior to the intubation for a whole other reason.
Definitely. This person asked, is there any recent guidance on cuff inflation volumes, or are we still relying on the Reebok pump method, inflate until it feels right and hope that the airway holds up?
This is really something that is so territorial with critical care pulmonologists and respiratory therapists. The amount of traveling I do, I would be erroneous here, pardon me, if I told you there was one way only this is being done. I'm going right now actively to 7 or 8 different hospitals. I'm seeing cuffs managed in a variety of different ways in the locations that I go. So whether RTs and critical care pulmonologists or intensivists are following the latest research, I'm sometimes finding that when I'm given that leeway, I may bring forward some of the cuff-related research, monitoring cuff research to them in a way that is not me trying to step on their toes. But I'm not seeing it managed one way all the time. I'm seeing a variety. And that could have an impact on that cuff pressure and mucosal irritation. Certainly possible. I wish I could say it's only being done one way, but it's not. And I have a pretty good sample size because the amount of traveling that I do. So
Definitely. This person asked, can you speak more to alternative management when acute and urgent ENT or laryngology is not available to diagnose an acute laryngeal injury and provide recommendations?
sure. Many of these scenarios, ENT has to be called in like almost like a specialty emergent basis only. So as I mentioned, I'll call them my best friends, my right-hand people have been pulmonologists in acute care in the close to 50 hospitals that I've been in consulting, training in some capacity. Critical care pulmonologists oftentimes have a dynamic understanding of the entire aerodigestive tract. Their bronchoscopy skills are phenomenal, many of them. So oftentimes they will scope, they will get a working diagnosis faster than an ENT can. They may send someone for a CT of the neck to get an impression from the radiologist. They may then, after they scope themselves and get a CT of the neck, then be the one to call the ENT and say, hey, we need some assistance with this case. But it is not, I will say, not always the ENT that is the person. And they, in many of my sites, we're waiting for them to show up, and they're not the person that's right there. So that's that route, pulmonary and getting radiology involved. When things are looking larger in terms of airway change, mucosal protrusions and such, those 2 disciplines have helped me. I will say just as much as ENT, particularly in LTAC. Most LTACs do not have ENTs wandering around, not in my experience.
So we had a question about the justification for intervention. So this person said, how do you justify early specialist intervention when some research shows that post-extubation laryngeal changes resolve on their own?
Yeah, so absolutely right. We've talked tonight about some of the changes, mild edema that may resolve on their own. You have to look at those factors tonight. The hematoma that I showed you. We're talking cases of a retinoid cartilage dislocation or retinoid cartilage subluxation, which is a partial dislocation, or the adhesion that I showed you, where those conditions are not, quote, going to just resolve on their own. So we need to, I will say, escalate that layer of support when something is well beyond just redness or edema, when vocal folds are not fully abducting, when granulomas are large to the size that they're going to be compromising the airway, and that TD article, 2 factors to cause reintubation. So it's a very, very big difference from a compromise to airway patency versus some edema, which may very well resolve on their own. And we can hear improvement to voice, improvement to breathing. We can hear breathing is easier. We can hear increased strength of cough. In the days following up, those patients are often getting less supplemental oxygen support. Their intake is getting better versus those cases where the medical team needs to manage. And so tonight's examples, the granulomas, the hematomas, those are the ones that just need the more, I would say, not urgent medical follow-up, but timely follow-up, where it's not something that's just going to, quote, go away. Where some of the edema and some of the redness does. Yeah.
We had several people write in and ask where they can learn more from you, and they were curious about fees, training, and competency. Would you be able to provide a little bit of information about that?
I'm not gonna sell myself here. If you think I can help you, you can email me at, is it okay to mention my email, Brooke?
Yeah, of course.
Okay. CEU customercare@gmail.com. CEU customercare@gmail.com. I'm pretty accessible. CEU customercare@gmail.com. If you have questions, training questions, maybe having me find for you the right mentor, the right training, I'm happy to try to help. I think why I do that is because when I first started out, no one helped me at all. So I think that if I can help someone, even one person here tonight, it makes our field better. So feel free to reach out.
Wonderful. And I know there were a lot of questions in the chat as we were doing Q&A about equipment, people kind of going back and forth about what equipment they use and issues with equipment and just talking about image quality. I know Dr. Blicker has experience with every single product on the market, so he is a great person to reach out to about that. Would you agree with that, Dr. Blicker?
Yeah, I'm happy to report that some of my main sites right now that are using, and I don't work for a scope company, but they are using and have been using really, some top equipment like Olympus. They're actually incorporating TIMS into their tower now. So that's nice to see. It's timely that I'm here tonight talking, but there definitely are differences with different systems, distal chip technology versus fiber optic that can impact quality of imaging. But I think that's same with some MBS equipment. I mean, it wouldn't be a fees only discussion, So I don't ever kind of give critiques on equipment. I can tell you right now, I'm using many different brands, and several of the sites I go are using TIMS software, incorporating with the existing tower. Does that sound like I'm describing that right, Brooke? I hope.
Yes, yeah. And the people in the chat, they were mainly talking about the differences between single use and
Oh,
distal chip
well,
technology, but
I mean, real quick, I don't know.
yeah.
A lot of us have to do with, it's like, when you were little, I don't know where you all grew up. I grew up in Long Island. We used to only be able to ride around the block on our bikes. And so you became friends with whoever was on your block. Then it was like you got older, like, oh, I can go down the street, I can cross the street, I can go to so-and-so's house, and you get all these new things, all these new adventures, right? So some of us are restricted in our choices for factors beyond our control. Some of us have a greater say in where we can go and riding that bike, quote, across the street. So in my knowledge, Olympus and Carl Stores make disposable scopes that are single use. I've used both of them. I'm okay with the image there. I like Carl Stores because you can do hybrid with a reusable and disposable scope on some of their towers. Ambu is a different company. They're a standalone single use. I definitely alter my scope position, how close I am to the airway during the swallow. With certain scopes that I use, I have a tendency to have boluses maybe adhere to them, to the material a little more, because some of the disposable scopes are actually, the material's different. I have had trials and tribulations on towers that cost, thousands of dollars with software. I've had trials and tribulations with single-use scopes where maybe I don't like the brightness. So I've been on a constant search, always trying to learn what's new and out there to get the best imaging that I can. Sometimes I don't want the brightness turned up too much, and sometimes it is. So I may alter brightness when I can during an exam. So I would say I don't use just one type of equipment. There's certainly a place for single-use endoscope technology. I'm not going to bat for them here by saying that. If you're in a critical care unit and you're stuck carrying a dirty reusable scope across a hospital to sterile processing, and you have one scope and it's going to take 5 hours to get that because GI and pulmonary are in line before you, then hey, having some disposable scopes as a backup may keep your referrals moving. So not everyone can afford 6 reusable scopes in their program. So I encourage people that if they have a scope for a reusable scope for a tower, whatever, and you're one of those groups that can get also reusable and disposable in the same system, but you can only have one reusable scope, talk to your director about getting a pack of disposables. Sometimes it's hard to get loaners, and so to have an ability to complete your exams, that can matter. So there's a financial component to that, there's an accessibility component to that, but there are some people that just prefer a reusable scope versus a single use, and that's fine too. There's enough out there right now. It's the best time to be doing fees. There's so much out there. Technology has improved so much since I was a new feeser, that there's really something out there just about every budget, every person. So
Definitely. And if anyone is interested in seeing all of the available equipment, we did a webinar last year called
yeah.
Fees Your Way that's on the website, and we reviewed every single
Oh, there you
scope
go.
on the on the market with price points, where it's made, the ins and outs of the equipment, reprocessing and all of that jazz. So you can check that out on our website. But with that, we'll close with a couple of housekeeping items. If you are interested in ASHA CEUs for this presentation, just complete the survey that I put in the chat. It'll also be sent out via Zoom, so check your email if you missed it in the chat. And we will submit for ASHA CEUs next week. And then if you'd like a certificate of completion, send us an email at tims-univ@tims.com. The replay for tonight's event will be posted on the TIMS website, and I'll include Dr. Blicker's email right below the webinar. So if you'd like to reach out to him, you'll be able to access his email right there. And I want to thank you all for being with us this evening. And Dr. Blicker, did you have any closing thoughts?
It was an honor to be here. Thank you for giving me your time. Thank you for spending time with me. I hope tonight was somehow helpful for you in some small way. And if I can help you out with anything moving forward in the future, let me know. Brooke, I hope I did okay.
Yeah, it was amazing. Thanks, Dr. Blicker, and thank you all for being here.
Thank you.
Bye, everybody.